All right. So, how was your week?
Good.
Yeah. How was your
Still a little sore in the morning, but like I said, after I sit at the computer for an hour or so, it sort of moderates.
That's okay. And what's the pill intake?
0.
So let's talk. Can we talk briefly about your situation? We were working together for what, about 10 years?
Yeah, 10 years at least.
And we kept the pain and we did mostly stuff that we're doing today, with the exception of muscle activation stuff.
Right, that's what you recently started doing, and that was to moderate an episode that I had.
Make sure the bone of the pelvis is okay.
Right.
We mobilize the spine by using flexion extension motion, bring the legs up and down. Do muscle work with some cream, Sombro cream, that cools it off a little bit. And now the vibration tool.
The vibration tool.
And then laser on it. And that's what we've been doing for about 10 years. And then it flared up real bad. You went to get an MRI. The MRI looks not. How does the MRI look?
It's degraded a little more than usual. I mean,
Okay, yeah, so it has some stuff in here that's not
continuing.
happy.
It's continuing to decline at a slow rate, but it is.
And you told what did you tell the doctor? It's beep off. That's what you can't say sometimes.
When he asked me what was wrong with my back, I said it was effed up.
Yeah, there you go. It's good you have a good attitude over it, actually, by the way. But then he wanted to do an injection, or he suggested we could do an injection.
He suggested doing injections on the nerves.
On the nerves, and then a second at UCSF.
And I went to get a second. I got a second opinion at UCSF, and they kind of pinpointed a particular area.
Right, they did pretty good, right?
Yes.
Right.
And
it was a team.
He said that he would inject that area with the local painkiller, and if that took care of it, they could go in and actually kill off that nerve that's causing me the pain. And he said it would be, like an outpatient thing.
Right. So those are two options that they gave you, and then in the meantime you were taking morphine, right?
I was taking huge quantities of codeine and Tylenol, and it caused me to have edema in my feet. And I managed to finally talk my primary care physician into prescribing low-dose time-release morphine tablets, 15 milligrams. And that took care of the pain perfectly, and the edema in my feet went down in 2 days. And about a week and a half or two after that, you did some new procedures that we hadn't done before, and
right, the muscle activation stuff.
Knocked the pain back down to where it's been for the last 10 years. So.
And so that's what
between taking the pills,
between a 1 to 3-ish, more or less, or maybe 4 if we get
3 and 4.
3 and 4 right now. Yeah, I mean it's certainly 10 years older than when we started, but it started out at a big pain initially.
It started out at 9 plus.
Right.
When I first came in here, it was real nasty.
Yeah. So. Well, and what we noticed with your situation is we have the SI joint here, the sacroiliac joint, where the pelvis is right here. The pelvis is high on this side, so it'll fall lower on this side. There's also this muscle here, the glute maximus, is not as active as this side, so that's part of the reason why the pelvic bones go out and keep going out. And so what we want to do is we want to address it by sort of massaging the joints and the bones back into their more proper alignment positions.
Well, so far, outside of needing to address when I had that relapse, one visit every 2 weeks is enough to keep me in good condition.
Right, and then that's the other thing. You're a case where we do have longevity on doing care. That a visit every 2 weeks, that built to about 25-ish a year.
Yeah.
One could argue that that's a problem, but I argue that that's not a problem.
The
in terms
discs
of-
and vertebrae in my spine are bad enough, so there's no way to keep them stable.
Right.
They need to be treated every so often.
And that brings me actually to the next point. You're a very good case where we can say, well, because we can see the MRI.
Yeah. It didn't look good.
It didn't look too good, and the medics didn't think it was too good either. The specialists.
No.
But we can keep you functioning, and it's a functional shift that we can try to do to the system as much as possible.
If you can keep me off the operating table and away from painkillers, what more do I need? That's the best I can hope for.
Well, no, that's very realistic. And we work this in conjunction with the physical therapist, right?
Yeah.
And so tell me a little bit about the physical therapist situation.
She was a good gal. She got me involved in doing some exercises that I can do at home, mainly core strengthening and and walking.
The core strengthening and walking. Mm-hmm.
And that seems to have alleviated some of the pain as well.
That's good. And I want to say to that, it is a nice connection between, I can talk to you about the active care, which we do a lot in here, or the trying to prevent re-injury stuff.
Well, yeah.
But you need often a person. If you have a person like your PT, it really helped in your case to have the reinforcement and keep the fine tuning.
Oh yeah, no, it did
together and all that. And I think we often, because the system often says, well, chiropractic and PT, why do you need both? I'm like, well,
because you do.
Because you do. Often it's a question of who you put first. If you only do one, you're lacking the system is so big. And it's not that it is so complicated, but it's so many parts that you often fare much better when you have two professional inputs on the functional improvement department inside, and not just on the pharmacological end of side, pharmaceutical end
Well,
of
the
side.
PT was giving me things to do that you don't do.
Right, exactly.
So
Complementary.
Essentially it's a complementary treatment for the same problem.
It's a very interesting.
Could be for the rest of my life. Who knows?
Well, it would have been a very interesting thing to have, MRIs every 3-4 years or something.
Yeah.
But not that we need to do the study like that. The end of the day, the important thing is your systematic function.
Actually, my latest MRI, I studied it along with the older one, and although it has gotten worse, it's not hugely worse.
So I will, we should almost have that be compared to some people similar to you that did not have any treatment.
I'm sure there's people with less damage than I have that are disabled a lot more than I have.
Well, that's a whole different discussion as well, correct? But I wonder, because the logic, the hypothesis is, in a joint, you want to keep the motion. You need to keep motion in the joint, that the joint is healthy.
Well,
if you don't put motion in the joint, alias the bone's stuck out of place.
Yeah, they stay active. I shoot pool.
That's right.
I shoot clay target.
I'm going to tell you, the muscle mass seems pretty good down here. But I guess I'm not going to say that.
I've been doing a lot of work around the house.
Oh, good. So then you look at really having good biomechanics.
Oh, yeah.
So you're using your hip hinge, you're keeping your core stable,
Yeah.
and you don't move out of the back.
And when I sit, I always sit straight up.
Well, that's good. You always sit straight up. And
in fact, for some reason or other, when I get up in the morning, I'm in a little more discomfort, but if I sit straight up for an hour, that takes care of it. So it's putting pressure in a different way.
No, it's true. Well, yeah, that is correct. Sitting up straight is not that bad. Sitting up slouch is horrible.
Yeah, well, I don't slouch.
Not anymore. You can't afford it. So I think we're getting somewhere with that. So what I want to do now is I want you to raise your thigh up, this side first, straight up. All right, good, relax. That about, and then try that. That's a little more motion. Let's do that again. Yeah, it's coming up a little, but you have to pull further from up here. Relax. So if I test that muscle, and again, that's the most outside gluteus muscle. I've got two parts to it, and I want to test it. So keep your knee bent and push up into my hand with your thigh. Push straight up. See, that activates it pretty nice. You felt that? Mm-hmm. Now relax here, so I can force it out a little bit. Good. And now from here, push straight up. Push straight up. Still, that's catching it pretty okay out there. Let's see how the other side functions in terms of that. And I'm not looking at your amount of ability to force. You know, it's not about Arnold Schwarzenegger versus whatever.
No, it's about how the muscle actually works.
Yeah, it's about the activation of it. All right, so this side, do that, push up. Yeah, it's shaky, you feel that?
Yeah.
It's skivvy out a little bit. Now let's go for this side, push up. That's not too bad.
That's better, yeah.
All right, now do that middle finger trick. Push up again. Yeah, so that's where we're going to go to.
That really made a difference.
There's a big difference, I mean, that rear mudra thing. So that's where we're going to...
It's absolutely crazy. There's no reason that should work.
No, there's no rhyme and reason that stuff should work like that. And it, you know, it's a very, very difficult challenge for a scientific mind.
Yeah,
but you know,
I can feel the difference that time. Sometimes I can't feel it, but today I felt it.
Yeah, it was strong. Well, and I felt it when you laid down. This was down a little bit. I felt something's off with this muscle. Although I always want to check that anyway. First, it's one of the main muscles that we need to check. Right out there, right?
Yep.
All right. So what we're doing now, we found the neurovascular point in the head that corresponds. You still on there in the head?
Mm-hmm.
That corresponds with the origin of that gluteus maximus sacral division. That's right on the sacrum here, where it goes into the bone. And I can feel the connection with the head point, so that's good. It is a working process. It is. I always look at these muscles like they're like animals. Hello, can you come back online? We need you. Makes life easier.
I'll tell you, when I had that relapse last time, I was really worried.
Yeah, that was a bad one. That was a bad one. That could have gone either way. We don't know these things, but I was amazed how... I mean, you came in one morning and you said, I stopped taking the morphine. I said, why you did that? You said, you tell me.
Yeah.
I was like, I guess this stuff worked somewhat.
Yeah. Well, the pain was back up to a 9 again. I mean, it was nasty.
No, yeah, it's a problem when it's messed up in the back. Like
I wouldn't be taking painkillers unless it was really, really hurting.
Right, no, you're tough. Yeah, I'm a sensitive animal. So now we're getting into, this is a lymphatic point over here, which we stimulate heavily on the rib cage, so usually on the rib cage. So that is connected with an insertion of the muscle and helps that muscle get more active, and I feel that. The insertion here, we're actually going pretty broad. Patches and
I can feel an effect, yeah, you're having an effect on that.
Yeah, you feel that?
Yeah.
I know. All right, now we're gonna bring that down there. Stretch it out the spindles a little bit more, and then we gotta go face up, please. Bend your knee. Lift up. Push against me upward. Push up. Push up. Push up. Juice. Feel the juice?
That's better, yeah.
I know. Good. Now let's do the other side real quick to make sure we have. Now we have an outer balance problem. And push up. Push up, push up, push up, push up. Now you got pretty good. Not as much as here now. You feel it?
The left side's stronger, yeah.
Yeah.